Thanks for joining the RxGeneIQ short patient scenario regarding blood pressure medication optimization using pharmacogenomics. In this patient scenario, you can observe how pharmacogenomics can personalize medication selection and optimize dosing. Additionally, you can see the concept of competitive inhibition, a form of drug interaction when multiple meds compete for the same enzymatic pathway. Let's introduce our patient for whom we used PGX to optimize antihypertensive medication. 66-year-old female on metoprolol who has lower blood pressure reading and lightheadedness in the morning after taking her morning dose of metoprolol. She's on metoprolol tartrate 50 mg BID. Please note that it is the twice daily formulation of metoprolol. There's also a once daily formulation of metoprolol, namely metoprolol succinate, but she's happened to be on the twice daily formulation. She takes this morning dose of metoprolol with her once daily bupropion Zyban, which she recently started for the indication of smoking cessation. There are two concepts that I would like to introduce to you as we optimize the medication for this patient. First of all, that she has gone through the pharmacogenomic testing because she's previously failed antidepressant therapy a couple times and went through the PGX testing to tailor her antidepressant therapy to her genes. So we know for this patient that she's a poor metabolizer of cytochrome P450 Her genotype dictates here on this three different pathway that I presented here. She sits somewhere here or here. So when a patient is an intermediate metabolizer or a poor metabolizer, then alternative medications are recommended or reduced dose. In this case, we recommended reduced dose of for her, and since she was a poor metabolizer, we recommended about 75% reduction of dose as long as she's on Zyban. And the reason we've done that is because Zyban and metoprolol are two medications that compete for the same enzymatic pathway. And so we have competitive inhibitions going happening here with metoprolol and bupropion. If you think about it, such as a highway, if you have metoprolol going through the road alone, then it can get metabolized and everything would be fine. But if metoprolol is thrown in with other cars, here we have analogy with other cars. If metoprolol and bupropion are thrown into this highway, they're going to compete, especially if bupropion, being a very strong substrate for this pathway, enzymatic pathway with 2D6, then it really is going to block the metabolism of metoprolol, and subsequently metoprolol doses will go up and cause some competitive inhibition here. So for that reason, the reduction of dose is recommended here. Please note that once this medication, or if this medication ever comes off the patient's profile, then the dose adjustment should be considered. On the other side, if the patient was an ultra rapid metabolizer, which means it was chewing up metoprolol really fast, then we would have recommended some increase in the dose, because with the regular doses we would not have seen effective antihypertensive effect. So for that reason, it used to be that when I became a pharmacist 20 years ago, we always had a package insert to guide us through what dose is an appropriate dose, and we always questioned doses that were too high or too low. But knowing about pharmacogenomics, in today's world, we know that there's really not a one dose that fits everyone, and there are instances where the pharmacogenomic and the genotype dictates higher or lower dosing, as you can see here. We hope this is a helpful case for you. At RxGeneIQ, we value our collaboration with providers and their referral. If interested, please feel free to view other patient scenarios or sign up to be on our mail list for future patient cases.